Thank you. So we are now going to switch, and I'm delighted to once again introduce Paul Wong. He is an attorney, and he also chairs the board of UMMA, which is a community clinic in South Los Angeles, and a clinic that's near and dear to the hearts of many of the Kaiser Permanente people in that community. And so with that, we'll hear from Paul and then have time for Q&A with him. So please welcome Paul Wong.
All right, hopefully I get this right. It's on? Perfect. Good morning, everybody. It was a little bit of a flight out here. I know Kathy and I experienced the weather. And so thank you for inviting UMMA and myself to this. I want to thank President Dillard, Dean Hill, Kamani, Alina, thank you, Kathy, and Kirsten. And members of the roundtable. UMMA. UMMA is a federally qualified health center. We're a community clinic based in South Los Angeles. The statistics up there, the information you see about South Los Angeles indicates not only is there a significant health issue for the community of South LA, but that the disparities are very significant given how close South LA is to so many affluent, some of the most affluent neighborhoods in the United States. It's funny, near where I work in Pasadena, I believe I have 2 Whole Foods. I can literally throw a rock and hit a supermarket of one form or the other, whether it is organic or commercial or even a farmer's market. South Los Angeles is the opposite. It is a food desert. Likewise, we have a lot of freeways. I'm sure you've all heard of LA traffic. South LA has a significant problem of transportation. For many of the residents of South Los Angeles, they may have to take 1 or 2 bus lines. Our vaunted trains and metro system doesn't really work for the people who need it the most. Hopefully I don't get in trouble for that one. I think the part to bring up the most is both jobs and housing. We all know there's a housing crisis. South LA is not unique. Our infrastructure is old. There are, unfortunately, a lot of slumlords and folks who are living in marginal level housing, and that impacts, these are some of the social determinants of health that impact the ability to not only receive care, but to get the care. Who is UMMA? UMMA is Universally Muslim Medical Association. It was founded by UCLA and King Drew medical students who watched the Rodney King riots happen. And I want to pause for a moment and just briefly mention that King Drew Medical School is a historically black university. And King Drew was founded in 1966 in response to the Watts riots. Fast forward 30 years, our clinic was founded watching the Rodney King riots happen. It is a community in crisis. It is a community that has experienced a lot of trauma, which I will cover in a little bit. So these intrepid students founded the clinic on the premise of their faith. Oops, jumped a little bit. There we go. We found a little place. It was a little daycare center that had been closed down. Our goal was simple. A community was in crisis. Our faith compelled, or the founders' faith compelled them to provide service. Our service population is largely, it is now largely Latino. So our service population is 70% Latino, 25% African American, and then everybody else is 5%. Members of the Muslim faith, our service population is under 2%. Our primary service is toward Catholics and other denominations. I bring that up because UMMA's model is unique in this one's respect. We were founded by Muslim medical students who became doctors. And through that connection, we founded a clinic in a neighborhood that we call our own now, but had limited contact to. Most of our medical students grew up in the suburbs of Los Angeles, far away from South LA. What we have done is bring to this community our resources, our donor base. I'm proud to call UMMA as the first FQHC in the United States founded by Muslim Americans, and because of that distinction, we have done a number of different things. And the first thing we've been able to accomplish is bringing resources to the community that would otherwise not be in this community. We don't draw from this community. We don't take part of the pie that exists there of other community resources. We bring our own. The second thing we are is because we are founded by intrepid young Muslim physicians and now many dedicated volunteers, we are able to bring that brain trust to South Los Angeles as a place of collaboration where faith and health and well-being come together. I had the opportunity to serve as the development chair for about 12 years. I am either Methodist or Episcopalian, depending on where I go with my kids. And I'm now serving as the board chair. And so we are a model of interfaith relationships and working together. Whenever I am in front of donors, whether they are Muslim or non-Muslim, whether they're secular, governmental, the first thing I remind everybody, very straightforward, is my faith compelled me to work in a community in crisis. What are you doing to help me make this work? And so to my Muslim donors, I guilt them because here I am, a Christian in a Muslim-founded organization, making a difference in a community not based on my service population being of the Muslim faith, but because this community is in crisis. Faith compels action. So the other part of our unique opportunity is because we bring this brain trust, we are able to engage in a variety of partnerships that we find innovative and breathtaking and sometimes very scary. One of the ones I wanted to cover is because I know I'm running a little bit short on time here, the Fremont Wellness Center. We partnered up with the Los Angeles Neighborhood Land Trust to put together a community garden at Fremont High School. So we have a community clinic there. We serve the students and the community. The Land Trust put together a community garden and a greenhouse. And what we have been able to do at this location is bring food to the desert, bring a safe space, a comforting space to this community in need. We work with high school students on behavioral health. We literally have addressing dropout rates, addressing community trauma. We work with students they are student leaders in behavioral health where they are doing a lot of counseling. We're working with them. We're also providing food information and teaching opportunities for the students at the community garden. We address preventive care. We address the issues of obesity and diabetes. One of the earlier slides you might have noticed, there's 25% of our service population is suffering from diabetes, hypertension. As a practical matter, if you don't catch young men and women and teach them about that, and my favorite quote that I always say, food does not come from a box. And if you teach them that it comes from the ground, that fresh fruits and produce can make a difference in your lives, then they begin to think beyond that box on healthy cooking, healthy ways of living. Because it's very easy to get fast food in South LA. It is very difficult to get fresh fruits and produce. So let me see if I got this right. one more. There it is, Fremont Market. So I wanted to cover this briefly. We partnered up with Food Forward, which is a nonprofit that collects fresh produce and fruits from different community farmers markets, from different organizations. And bi-weekly, we are a site where we give out to the community free fruits and vegetables. And we are now, starting in March, a distribution center so that other community organizations can also become a site. So we're giving about, I want to say, 2,000 to 3,000 pounds of food bi-weekly, and about 15,000 pounds of food we are a distribution center for. And this is a bi-weekly program. Why is this important? Health and eating well and wellness are all interconnected. That is a realization that I think we all understand intrinsically. If you go into South Los Angeles, if you are working with a population that is either fearful of the government, that has a limited education, or worse, simply prohibited by virtue of transportation, by virtue of the food desert, that they don't have access to fresh fruits and produce, that the foods that they're used to from their, wherever they may have come from, that this becomes an opportunity for them to re-engage in the world that most of us share and experience on a daily basis. You can go to a supermarket and pick up a bunch of oranges. A lot of folks in South LA cannot do that. And so UMMA's partnership with these different organizations comes about because we're not afraid, but more importantly because we bring to bear partners and different folks willing to commit of their time and effort and energy, not necessarily within the community, but that we share the same faith, or we share the same desire to put faith in action. This manifests itself not only in our collaboration with community groups and community partners, but we have connections with UCLA, we have connections with USC, Charles Drew University, and we bring students and medical students onto our clinic for rotations, for volunteer opportunities, with the hope of training future doctors, public health workers, and students to view South LA as part of their neighborhood, part of their home, and not somewhere to be feared. And so I'm proud that we can bring students to our different clinical sites, rotate them through so they meet the residents of South LA, see them as individuals, see them as people, and see them as caring and loving people that they can also care and share and be part of their lives. We've had a number of students go through there. A lot of our medical students have continued on, and they are in primary care. They do work in urban environments, despite the high-paying jobs that may be available in the different suburbs. And I think if you can get students, and UMMA believes this firmly, if we can get students to see the residents of South Los Angeles, they will not be afraid of serving in South Los Angeles. We partnered up, we developed a grant with Community or California Hospital Medical Center, part of the Dignity Group, where we came up with, well, we didn't come up with it, but we implemented in South Los Angeles a readmissions program that was specifically designed to try to break the cycle of having patients go from hospital, emergency room, to emergency room visit, to emergency room visit, and instead change the model so that we can get these patients comprehensive care after they get out of the hospital, to break that cycle. So we started a pilot project where before any patient was discharged from California Hospital, we had our social worker there setting up a follow-up appointment within 72 hours after being released from the hospital, and then making sure that not only their emergency and chronic needs are being addressed, but that comprehensively we're looking at them from a perspective of, I don't know, either dentistry, mental health, and things like that, with the goal simply of breaking that cycle. It has been successful. I want to believe we have some statistics on that, but the important part to bring up is that we were able to reduce readmissions rates significantly, very significantly. And California Hospital, and I know a number of other hospitals, are starting to utilize community health centers as a partner model or a partner in this process. It used to be that hospitals were afraid of community health centers. I've been on this board long enough to know that. And they've heard us because we would take from them or vice versa. What we have found through this pilot program is that as a partner, their care improves, our care improves. Hospitals are able to care for the sickest, the neediest. Community health centers get to do the thing we do best, which is preventive care and chronic care. And between the two of us, we literally achieved a wonderful outcome for a lot of our patients. And so it works, and I encourage everybody to look at that model as well. I know my time is a bit limited, so I'm going to pause here. And so if you're curious, you're welcome to look us up at UMMAclinic.org.
I'm just here to open up the questions, and I'm reflecting on the prior speaker who talked about moral imagination, and you just gave us a feast of that. So thank you so much. So please, Amy, and then be thinking of your question. If you can raise your hand so Kamani can get to you while we're listening to this dialogue, that would be great. Thank you.
Thank you so much for your presentation. One of the questions that I had, it seems like you have all of the pieces necessary to make this work. Thought about, or are you doing anything related to socioeconomic opportunity? Because you are working with the educational sector, or maybe through your food access program?
The short answer is yes. We're part of a literacy program. We very much involve ourselves in those issues of social justice. So, for example, we have a tax day. We have partnered up with a number of tax accountants. We have a law day, a legal clinic day that we sponsor, where we have reached out to attorneys. Again, it's easy for me to say this. We put a call out to the Muslim professionals in Los Angeles area, and we say, look, we got a tax day. You're an accountant. We need your help. And what we do is we literally provide a clinic on helping people file their taxes, preparing and answers. For our legal clinic, we work with the issues of housing and simple issues. We do our best to try to address issues of access and social justice in every single sense of that word. We have a very strong behavioral health program. We just bought a new site so we can literally provide behavioral health away from the regular clinical environment, just so that people recognize that health, mental health isn't necessarily a physical thing, although I have to be careful about what I say about that. But the point being, again, simply, we try to be a thought leader on these issues, in part because we can draw from a different donor base. Most FQHCs I know do not have the model we have. We have donors that we look outside of the local community, and people want to partner with us because we're not drawing from them. And so I guess if I were to make one tie here, as people of faith, you're not limited to the local environment. There is a national or state or regional center of folks that, if you can just actuate their faith and their belief in service, That's how you get them to provide beyond their own four walls.
Morning, Andre White, Durham Parks and Recreation. You talked about the great partnerships that you have with the different organizations, agencies in the area. My question was regarding the community. How did you get the community to buy in? What challenges did you face in terms of community organizing, rolling out the program to the folks in the community?
So that's a very interesting struggle in itself, and I could spend about 3 or 4 hours about some of the struggles and some of the amazing partnerships that we've engaged in with the community. South Los Angeles was largely African American, and over the last 25 years has gone from largely African American to largely Latino immigrant population. And so as part of that cycle of change, we've had to learn to work with different community partners. We've had to work with folks that English is not their first language, and in fact Spanish, they speak a dialect of Spanish that if you took Castilian Spanish in high school, they would look at you and say, no comprende. And the point of that is to try to keep this as short and as narrow as possible. I am a firm believer, I have said this over and over at our board level and at our employee level, that we are not experts parachuting into a community to tell them the answer. If you do that, you turn them off. What we are partners offering help and assistance. We work in a culturally sensitive manner, consistent with our beliefs, but we don't impose upon them, on anybody who seeks help, that we work with them, that we say, what can we do to help? And we offer what we can help and see how we can fit into their schedules. Because if you assume you're the expert, you will turn them off. Now, I can tell you this as an attorney, because the first time you hear, I'm an attorney, and if you're a physician, you're like, oh, it's the devil, all right? And that's the point. I actually refuse, and I make it a point on my board that there are no titles. We all talk to each other by our first names, because our patient consumer board members, Dr. Wong, Dr. Smith, Dr. Jones, no, it is Paul, John, Sally, whatever. And the reason is we must be equal. We must be in an area of responsibility and respectfulness. I hope that kind of helps.
Paul, I appreciate your reflecting back on the history of health centers sort of viewing each other as competitors for a while. And for a few of us here of a certain age, there's another dyad that occurred in the 60s when community health centers were set up because of racial discrimination. Yes. Because the state health departments and the large metropolitans were not, the feds were sending their money to the health departments, which for reasons of discrimination were sending it primarily to the white community. So the community health centers were set up for that reason. And then over time, and there was a good deal of competition and animosity between health departments and the community health centers back in the day. And over time, they've viewed each other as partners serving the same, just as now hospitals are starting to see the same opportunities for collaboration. So interesting, just a comment.
No, absolutely. And I just, well, as a brief comment, historically, health departments viewed community health centers as interlopers into their, and hospitals are starting to come around exactly in that sense. But I will say this one thing. It really helps when your public health folks, your state and local officials are supportive. I guess I should mention, We held, for example, on community trauma, our California State Assemblyman had a hearing at our Fremont site on the issue of community trauma, and we were a host of that. And the opportunity was to bring people from within the community into this environment, away from a hearing room up in the Capitol, but right inside the community. And different voices were brought in because they knew this community garden. It's a safe and it's an open area. And so by getting government involved, by getting folks involved, you can begin to create different alliances and, again, learn to speak to each other as equals. I think there was, yes.
Bob McClellan from Dartmouth. I wonder if you could expound on what it is. So if you were fully funded by the federal government and you had all the money you needed that came from fee-for-service, what is it that this faith-based mission that this and the donor passion that comes to this brings that you would not have otherwise?
So, great question on how, if you're fully funded via, oh, I turned it off, so let me turn that on. I think we had a slide that I zoomed through that gave an idea of the pie. So, sorry. There. Okay. So, if you're looking at this particular slide, you'll note that for us, the majority of our services come from fee-for-services. Because we are beyond federal funding, we are able to tie into foundations, we're able to tie into different kinds of grants. So, for example, we did a breast cancer study with the Susan Komen Foundation, where we were studying health disparities on breast cancer awareness and treatment and the follow-up within the Muslim women population. And the reason we were able to do that, and the reason we were able to engage in innovative projects, is because we are not 100% reliant on federal funding. Once we broke out of the mode of reliance solely on fee-for-services, we have excess capacity, if you will, to take on different projects. That's why a lot of our partners are excited to work with us, because we literally can bring more to bear. We're not just a health center. So we have the ability to talk about legislative activities, health issues. We're interested in health policy. Frankly, we cheat. UMMA draws on all these Muslim, young Muslims and other folks of faith that want to do something mission-driven, and we're not afraid of taking on a project or a policy directive. Sometimes it's scary, but that's the advantage of moving away from a fully funded, government-funded, through health services, to thinking about policy, to thinking about implementation of different strategies to address the social determinants of health. I hope that answers it. I know there was another question.
University Divinity School. One of the things I really admire about community health centers, there are many wonderful presentations. If I'm correct, the majority of the board members have to be patients or consumers, and that model has seemed to work very well throughout the years, and is a model that it appears we could use in other organizational entities as well, including engagement of faith communities. Are there a couple of take-home points you can share with us about how that model has worked for you?
Yes. So community health centers have a model in which 51% of the board must be a consumer of the community health center itself or clinic itself. And this is an important detail because, and I think most FQHCs can speak to this, the reality is I don't live in South LA. I practice in the South LA area. I meet with folks there. I go to the clinic, but I'm not a consumer. And so when you have a consumer board member, talking about their experience, sharing what it's like to be in the clinic, sharing what it's like to be in South Los Angeles. The way you shape your care, how you view the statistics of service, and how you talk about care provision changes. And so it's a struggle. I will tell you, we are always, and if anybody in South LA who is a community member interested in joining the UMMA board, I'm happy to talk to you afterward. So now that I've said that, it is always a struggle to find consumers who will serve on the board. But it is uniquely gratifying because, again, if you don't know what the services are about, then you're a number. And as a board, we can't look at it as numbers. These are patients needing care, love, and compassion. And if you don't have it, then I encourage you to bring board members on who are members of your community that are taking advantage of your services because they will bring a perspective that is different. And I can tell you this because I have doctors on my board, I have lawyers on my board, we have accountants on our board, and I can assure you, when we chat, we talk a different language. And when you talk that different language, you turn off everybody else. And in order to reframe that conversation, you have to have balance and to be conscious of it. That's why everybody knows, if I catch somebody saying Dr. So-and-so, I really don't like it. And I get really mad about that, and I emphasize that over and over because we are equals. If we cannot be equal on name, then you've already created the barriers. So I apologize to anybody if I didn't call you doctor in advance, but that's just how I feel. And that's how we do it on our board. Thank you.
Thank you so much.